consultant DMD surgeon, pediatric airway specialist, Ernakulam Medical Center, and myself, Dr. Lakshmi Venkitraman, who is consultant DMD surgeon in General Hospital, Ernakulam. So I was invited to speak in this platform based on an article which we published in International Journal of Neonatal Surgery. So I thought I would start off the presentation by giving you a brief on the case itself. So we had a 45-day-old baby who presented to us in the casualty with chest indrawing and stridor since birth. The baby was born full term and did not show any dysmorphic feature. And the child was in fact misdiagnosed elsewhere as having laryngomalacia, and they were assured a spontaneous recovery. But at the time of presentation, the situation was worsening, and the child started showing symptoms of failure to thrive. So this is a picture of the baby, and here you can clearly see the baby had subcostal retraction, substernal retraction, use of accessory muscles, holding of the supraclavicular fossa, and in the next one, I shall play you the video where it is very obvious. You could listen to it. So the child had inspiratory stridor, excessive use of accessory muscles of respiration with severe chest indrawing. So we were in doubt about the diagnosis of laryngomalacia, and hence we decided to take the baby for fiber optic laryngoscopy. This was done in our casualty with the help of a team of pediatricians and anesthetists. And this is a video of the laryngoscopy. So this gives you a better picture for those who are not familiar with the fiber optic view of the larynx. Here you can see this is the laryngeal inlet. This is the dynamic picture because the baby is awake, the baby is crying, the baby is breathing, swallowing, and this gives you a real-time picture of what exactly is happening when the child is in fact inspiring every time. So the pointer here points out to a large cystic mass which occupies the vallecula, and it is pushing the epiglottis posteriorly and thus covering the entire laryngeal inlet. This is for those who could not make out. This is a normal picture of the laryngeal inlet of a neonate, and I am pointing out to the epiglottis, which is the most obvious cartilage when you go in. And this is omega shaped, which is a normal finding in a neonate. This is the laryngeal inlet. These two white structures are the vocal cords, and this leads to subglottis, and subglottis leads down into the trachea. So when the baby is breathing, in fact, the epiglottis opens up well. So the inspired air goes in and the baby is able to breathe comfortably. But in our case, as you can see, this is the large cyst which occupies the space behind the epiglottis. So this leads to compression of the epiglottis, which falls over the larynx and compromises the airway. And this has led to the noisy breathing and inspiratory stridor. Hence, it was clear from fiber optic scopy that the diagnosis of laryngomalacia is not true, and wait and watch is not the solution to this situation. Next, we took up the baby for the MRI scan. We just knew that there was a lesion in the vallecula. We were not sure if it was a vascular lesion, if there was any connection to any other passages around. Hence, an MRI scan was done, and the diagnosis was confirmed, and it came up as a thin-walled cystic lesion. It was measuring about 1.5 centimeter in diameter, and it was occupying the vallecular region. The infant laryngeal diameter itself is only about 4 millimeter. So you can imagine the amount of compromise the airway was undergoing for the 45 days, initial 45 days, and this was what led to the stridor and failure to thrive. So we decided to take up the baby for surgery. Initially, we tried to intubate the child. The anesthetist tried to put in an endotracheal tube, but because of the large cyst which was obscuring the view, intubation was failed. Hence, we took up the baby for an elective tracheostomy. Uncuffed tube of size 3 was used, and a direct laryngoscope with a straight blade was introduced into the airway. And we used a newer technique, which is known as a Coblator. in order to marsupalize the cystic wall. We opened up the entire anterior wall of the cyst. I shall play the video for you. So if you can see here, this is what the Coblator wand looks like. And you can see we are nicely opening or de-roofing the anterior wall of the cyst. And this opens up the entire cystic wall. We have to open it in such a way that the two margins of the cyst does not come into contact with each other, and the entire cyst is exteriorized. As you can see, the usage of Coblator has its own advantages. First and foremost, there are various sizes and lengths that is available for us to engage the instrument at different depths of the airway. Secondly, it has the property of both coagulation and coagulation. Third, there is very minimal thermal energy that is released. It is about 40 to 70 degrees, and hence the thermal tissue energy in the surrounding area and the surrounding airway surface is very less. And last but not the least, there is very, or I must say, there is no bleeding at all. Airway being a very challenging part of the body. If there is bleeding, it can compromise and obscure our vision. Secondly, we have used an uncuffed tracheostomy tube. So if there was any bleeding that was to happen, then there would be severe, it can compromise the airway. So these were the advantages of the Coblator, and this is the picture of the baby after 1 week. This is the direct laryngoscopic view, which shows that the entire cyst, the wall of the cyst has collapsed, and it has given us enough and more space for the epiglottis to move forward and backward, and completely opening up the laryngeal inlet. The child was completely free of stridor after 5 days. So you can see this is the laryngeal inlet, this is the collapsed vallecular cyst, this is the epiglottis. The child, this is again the Coblator wand. I just wanted to show you the tip of the wand. These are the electrodes, and I'll just come back and let you know how the Coblator in fact works. The child was connected to the ventilator immediately post-op, and the next day she was taken off the ventilator. The tracheostomy tube was closed to see if the baby was tolerating it, and on day 3, the tracheostomy tube itself was removed. On day 5, the child was completely out of stridor. So what do we understand from this? Endoscopic marsupalisation with Coblator is the key to surgical technique of dealing with laryngeal cyst, especially vallecular cyst. And like I said, there are several advantages of Coblator wand, starting from minimal thermal energy production, very reduced tissue edema, which helps in reducing the post-operative complications. Third thing was there was very minimal bleeding. 4, ease to use, and 5, various sizes of the wand is available to help us guide through various portions of the airway. Now it works by passing radio frequency through a conductive medium. So we have continuous irrigation with isotonic saline that happens in the field, and radio frequency passes through this. This leads to creation of a plasma field that helps in intercellular breakage. Now this irrigation also helps to reduce the surface temperature, and we have a suction port which is inbuilt within the Coblator wand that helps in removing any smoke if that is produced, excess of fluid that comes into the field, and in case if there is any bleeding, that is also taken up by the suction port that is provided. When you compare the thermal energy produced by the Coblator to that of a bipolar, which was previously used, I must say, bipolar emits about 400 to 700 degrees Celsius, while that of a Coblator is only about 40 to 70, and with proper irrigation, the temperature can be brought down to much lesser degree. And the tissue penetration is less than 1100 micrometers. So what are the points to ponder? How do we come to a diagnosis? How do we know if a child comes to you with stridor, if a child comes to you with chest indrawing and other features of compromised airway? How do you come to the diagnosis? Second thing, why is pediatric airway so challenging? Some of us are well versed with taking care of adult airway. We do bronchoscopy left, right, center. But when it comes to a pediatric case, especially a neonatal case, what makes it more challenging compared to an adult airway? And how do we overcome these difficulties? Now that I'm in fact, it is the first time I'm speaking in a forum where there are so many mixed, it's a mixed population where we have pediatricians, we have gynecologists, we have intensivists. So I thought I would just, quickly tell you some of the important things that you need to keep in your mind when you're dealing with a pediatric airway. First and foremost is everything starts with anatomy. There is great deal of anatomic variation when it comes to adults and pediatric. In pediatric, we know the single most important parameter which guides us towards a baby's development is the head circumference. So the child has a large prominent occiput, while that of an adult is flat occiput. The tongue is relatively large, which obscures most of the space within the oral cavity. The larynx is very much higher up. It usually lies opposite to C2, C3 vertebrae, while that in an adult is opposite to C4 and C6. It is much lower down. Epiglottis is omega shaped. It is soft and flaccid when it comes to an infant and neonate. While it is more horizontal, it becomes more thick, it is flat, and it is more stiff when it comes to adult, helping us to deal with an adult airway in a more relaxed manner. Vocal cords are short and concave, while it is horizontal in an adult. And the narrowest portion is the subglottic level, which is the cricoid ring area when it comes to a pediatric age group, while it is the laryngeal level or vocal cord level when it comes to an adult. The cartilages are soft, and the lower airways are not as well developed as in the case of an adult. So this is the shape of the epiglottis. In a newborn, you can see it is like an omega, the omega shaped epiglottis. While you come to an adult, it is large and flat, and it is as if the neonatal epiglottis is somehow hugging the laryngeal inlet, making the visibility much more difficult, and this improves as the child grows up, and to an adult stage it is much easier when compared to a newborn. So once again, the babies have large occiput. They are pure nasal breathers. They have large tongue, floppy epiglottis, anterior and high larynx. The trachea is more funnel shaped because the subglottis is the narrowest level, and then it goes down, and the narrowest part again is subglottis. Now, another thing which needs to be remembered is that the effect of edema is much grave when it comes to a pediatric airway. In normal pediatric airway, the narrowest part is about 4 millimeter. So if you could imagine a situation where an edema of 1 millimeter is created in the airway, you can see the radius of the the entire diameter comes down to 2 millimeters, which is a very compromised situation. But if you think about from an adult, in an adult, when the diameter is 8 millimeter, if there is edema of 1 millimeter, still the adult has got a diameter of about 6 millimeters, which is only 44% reduction in the cross-sectional area. And this can, in fact, buy us enough time to, plan our procedure further. But in an infant, we need to act quickly because it doesn't take much time for this 2 millimeter to completely obscure the airway. So what do we do when a child presents with possible airway pathology? So these kids can come to us in two different ways. One is where the child is in immediate danger, and the other is where you can breathe, you can think, and you can plan up your steps. So always assess the airway, inspect. All these things can be done in say 10 to 15 seconds. You inspect, look for chest indrawing, look for labored breathing, assess the upper airway, look for any drooling, look for any nasal secretions, look for dysmorphic features, hear out the breath sounds, see if there is stridor, and always look for retractions. Assess the breathing, look at the respiratory rate, measure the temperature, and see if infection could be one of the causes. Take a proper history if you have time. Take an antenatal, natal, and immediate postnatal history. Take a thorough family history. Ask for any recent infections. Obstructive sleep apnea is another thing which we are commonly seeing. Many of the syndromic babies do present with obstructive sleep apnea. Ask for history of OSA. Look out for stridor. See if it is inspiratory, expiratory, or if it is biphasic noise. Ask for any recurrent pneumonias, which points towards aspirations, and that again tells you that there is an anatomical change that is happening in the larynx. Ask for any atrophy or allergy, and look for syndromic features. Again, one more important entity that usually we miss out is history of any forgotten foreign body, ask for any history of violent cough episode, listen to the breath sounds, put in a stethoscope, and here see if there is any discrepancy in the breathing of right and left lung. And if you have time, then you can go ahead, do a few diagnostic tests. You can go for a radiology, and in case if it's a foreign body, you will very well see one side of the lung is collapsed, and you can do a fluoroscopy to rule out any history of aspiration. And fiber optic laryngoscopy is the key to directly visualize the larynx, and which will tell you right at your face what the problem exactly is. And the next step would be to go in for a rigid laryngotracheal bronchoscopy. If the airway is compromised, do not think about any of these things. Directly think about securing the airway. And how do you do that? First of all, you have to keep your instruments ready. If you are a center who is going to expect pediatric airway cases to be referred from other centers, I'm sure you will have a drill. You'll have a group of people who are going to just rush in from all directions and help you out. You're going to have nursing assistant. You're going to have pediatrician and the anesthetist coming in to help you. Secure the airway, which can be done using a nasal airway and oral airway based on where exactly the pathology is. You can try for endotracheal intubation, and if that fails, the next step would be to go for an emergency cricothyroidectomy and then a tracheostomy. What are the equipments to be kept ready? And I would say always and always, it is better to anticipate threat and keep things ready. I would say my team comes to me with SOAP-Me, suction, oxygen, airway, pharmacology, and monitoring equipments. Suction catheters and Yonker tips are very, very important. You have sizes available from 6 to 16. A pediatric or neonatal age group would benefit with up to 6 to 10, I would say, French gauge suction catheters and Yonker tips. Yonker tips are blunt plastic suction catheters, which are very useful when you want to suction away the secretions that is pooling up in the oral cavity. Keep oxygen ready. Check if the cylinders are full. Check if you have enough flow in there. And keep nasal cannulas, bag and mask ready and at hand's reach. You decide on what kind of airway you are going to attempt to. So keep endotracheal tubes based on this age all ready and set. Keep the normal nasal and oral airways ready. Keep stillets to guide you, and laryngoscopes. Laryngoscopes, always check for the flexibility of the scope, the size of the scope, and see if the light is working. These are the small things which will put you in soup in the last minute at the 11th hour. So make sure this set is being checked on a regular intervals. Make sure you have a team who's going back and doing a thorough check on this on a weekly basis at least. And have your pharmacology things ready. Ask your anesthetist to kindly come in, help you out, or the intensivist, I would say, to help you sedate the baby, and keep the monitors ready. You have to monitor the saturation. You have to have your stethoscope. You have to put in your ECG leads and end-tidal carbon dioxide, especially when you're planning to go in for an endotracheal tube, to make sure that the tube goes in right into the trachea. This can be tricky, especially when you are anticipating anatomical variation in the laryngeal inlet. The tube can have abnormal connections, fisculous connections, and hence, in order to make sure the tube is going right into the trachea, end-tidal carbon dioxide monitoring is very, very important. Now, I would like to highlight the point of fiber optic scopy when you are in fact trying to diagnose a laryngeal pathology. Laryngoscopes can be flexible and rigid, and flexible scopy is, I would say, the most important and valuable equipment you could have that could help you to diagnose laryngeal pathologies. Why is there some amount of learning curve difficulty when it comes to flexible scopy or even rigid scopy? It is just that the portal of entry is either through the nose or through the mouth when it comes to rigid scopes, and nose when it comes to flexible scope. So you have to, the portal of entry is over here, and you have to in fact view the structures that are located in this area. So it is most important to have a straight line, or axis of visualization has to be made straight from the mouth to the larynx or from the nose to the larynx. If it is a flexible scopy, this challenge is taken care of because the scope itself can bend. But in rigid scopes, that is not the case. You have to bring the line of visualization in a straight line so that the scope can directly take you to the area of interest. And this is the way you have to position. You must do a drill on positioning the baby, which is very important. So if it is an infant, as we discussed, the occiput is large. This itself will give enough cushioning. Hence, the correct positioning is when the anterior end of the shoulder and the external auditory canal lies in a straight line. So in an infant, because the occiput is large, you need not give any cushioning at the occiput. You just have to put up a shoulder bag. Now, when the child is slightly, when you have a smaller child and not an infant, you can see the occiput size is reducing. Hence, you may not need any sort of back support here. All you need to do is slightly extend the neck, and that will give you a straight line of visualization. But when it comes to older people or adult, you will have to give them a support under the occiput. For various reasons, one, most of the old people and adults might have a cervical spondylosis and related fixity to C1, C2. Hence, hyperextension may be difficult if you don't give a support here. You cannot have the occiput hanging down, and these are the individuals who will need a hyperextension. So that needs to be achieved. Only then you will be able to directly pass it at rigid scope to visualize the larynx. Now, what are the blades that's available? These are the things which must be at hand's reach in a emergency setup as well as in an OT. Have your laryngoscope blades. So you have the smallest to the largest size, which can be measured approximately from the angle of mandible towards the tip of the incisor, and this might this will give you the approximate size of the blade that needs to be introduced. It has the light source, and this needs to be checked every now and then. And the second picture is direct laryngoscopes. These are rigid scopes, and these require positioning of the patient before you introduce it. And you have a handpiece that is that has got a slot. The slot can be attached to a chest piece, in fact, and that will give you enough stability. You can pass all the instruments you need through this port. You can pass the light cable and carrier. You can pass the suction. You can pass the Coblator wand. You can pass rigid endoscopes. You can pass I would say forceps, all that you need through this portal of entry once you have reached the area of interest and once you have fixed the blade. Now, this is our favorite instrument, I would say, the fiber optic scope, which are available in pediatric as well as adult sizes, 4 millimeter adults and about 3.2, 3.4 millimeter in pediatric, which gives you enough space to work around and would directly take you to the laryngeal inlet area. So I thought I would talk to you in brief about two interesting, congenital anomalies, especially because it was brought up within our case. There are several other anomalies, and I won't be talking about all of them. First, I thought I would talk to you about the most common and the most commonly misdiagnosed, I would say, congenital anomaly of the larynx, which is laryngomalacia. Laryngomalacia just means flaccidity of the laryngeal cartilage. The laryngeal cartilage, which is supposed to nicely open up the laryngeal inlet, especially during work of breathing, collapses on itself. It starts, it becomes floppy, and it compromises the airway inlet, leading to a noisy breathing. This also happens because of delayed neuromuscular tone or hypotonia, and usually the child presents with airway obstruction, and the stridor, which is usually inspiratory, high-pitched, like what we saw, but they usually have a later presentation. They usually present later in life, say about 8 to 12 months. Immediately after birth, laryngomalacia is not very common unless and otherwise associated with some other laryngeal pathology. But their cry is usually very clear, unlike the baby we saw here. Cyanotic attacks are uncommon, and they usually have choking episodes, difficulty in feeding, coughing, and poor weight gain. How do you work up? Go ahead, do a flexible optic laryngoscopy. Now, again, when I want to trust on the fact that fiber optic laryngoscopy is advantageous in many ways. One, it is easy to use. Second, it is less traumatizing. Third, it does not require general anesthesia. You can just sedate the baby and go ahead and do it. Four, the learning curve is not so difficult. Five, I would say you will get a dynamic picture. I think that is the most important, most important point there, because you are in fact seeing the airway in a dynamic way, as it is when the baby is awake, when the baby is crying, when the baby is swallowing. There are also situations where, in fact, we feed the baby with the fluorescent dyes, which is radioapaque at the same time, which is safe for the lungs, and we feed it through the milk, and we can in fact assess how the swallowing is while doing a flexible scopy. And the child is made to swallow the milk, and you can see if there is any spillage, you can see if there is any signs of aspiration. Now, also think about sleep study, because most of the laryngomalacia cases, because it is, I would say, floppy cartilage at the larynx, there can be collapse of airway at multiple levels, which is the basic pathophysiology of obstructive sleep apnea. So you can view the entire airway starting from the nose to the nasopharynx, to the oropharynx, to the hypopharynx, to the larynx and immediate subglottis. And if your scope would take you down further, you can even go ahead, have a look at the trachea and the main bronchus. Now, most of the times, laryngomalacia is dealt by conservative management. You can try a course of proton pump inhibitors, H2 blockers, advise caretakers regarding positioning of the baby, lateral positioning, head up positioning, and modify the feeds. Avoid loose feeds and go for thicker porridge consistency feeds that reduces the chance of aspiration. You do have situations where you have to go in there and manage surgically, where when the conservative resorts are not helpful. So those are like supraglottoplasty and epiglottopexy, where you basically do procedures to stiffen the laryngeal cartilage. Now, the second entity what I wanted to bring into highlight today was this laryngeal cyst, which is basically a vallecular cyst when it sits in the vallecula. And it is said to develop from minor salivary glands, and there are various classifications to it. I would just skip that and come back to investigation. Again, I would like to emphasize on the point of usage of fiber optic evaluation of airway. And here you can see the larynx again. This is the epiglottis. This is epiglottis, and the cyst sitting over here is a vallecular cyst. And you can hardly see the laryngeal inlet. And if there is compromised airway, like in our case where we were not able to do a endotracheal intubation, you might need a tracheostomy. Some people try to buy some time by doing a needle aspiration, because the cyst is usually filled with fluid. Some do IND, but the problem of these is that the cyst wall, it gets recollected, the fluid gets recollected, and there will be recurrence. Hence, the definitive treatment is deroofing / marsupalisation of the cyst. So what is the take-home message? Take-home message is that all striders are not laryngomalacia, unless you have gone in there, unless you have seen it, unless the laryngoscopy picture has spoken for itself. Fiber optic visualization is a must. You need to be well versed with the procedure. You need to learn it. You need to master it, and that is going to directly lead you to the diagnosis and proper management. Wait and watch. Let's wait and watch. And conservative management is not always, even though it sounds great, it sounds good to us, it sounds good to the patient, it sounds good to the caretakers, that is not always the proper solution. And it is the single most important and effective key to management. So what happened to the baby? So this is where the baby was, a 45-day-old baby with all the features that I mentioned before. And this is 1 month after recovery. And we couldn't help but, be happy for the work that was done. And I would like to play this video where the child is happy, playful, breathing well. There are no signs of retractions, no signs of labored breathing. The child is happy like any other child. And right now, this is where the baby is. This was a picture which was sent to me today by the father. And so I think the picture speaks for itself. I would like to thank Dr. Pradeep for his immense support and guidance, family and friends for their faith, and team Midwifery for their for the opportunity and recognition, and especially the patient and parents for their concern and cooperation. So this is the article that was published in Journal of Neonatal Surgery for anyone who is interested to have a look at it. And thank you so much. Thank you.
Thank you so very much, Dr. Lakshmi, for that excellent presentation there.